Welcome to another PrecisCa tumor board. Great to have a world-renowned faculty to discuss these cases. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and a thoracic medical oncologist. And again, joined by a wonderful group of faculty. I'm going to allow them to introduce themselves. We'll start with Dr. Bala.
I'm Sanjeev Bala. I run the cardiothoracic imaging section here at Washington University in St. Louis. It's good to be here.
My name's Wally Curran. I'm the Chief Medical Officer globally for Genesis Care and Professor and Director Emeritus of the Winship Cancer Institute of Emory University.
I'm Varun Puri. I'm a thoracic surgeon and professor of surgery at the Washington University in St. Louis, along with Dr. Bala.
I'm Ross Camage. I'm the Director of Thoracic Oncology at the University of Colorado. I'm a medical oncologist and delighted to be here again.
This is a stage 2 adenocarcinoma. This is a 78-year-old female former smoker, 50-pack year, with an incidentally detected right upper lobe nodule. Patient is status post minimally invasive right upper lobectomy with an adenocarcinoma stage 3, a T2N2. Question that we will try to answer is, what is the preferred systemic therapy, and is there a role for post-operative radiation therapy? So this patient presented with mild dyspnea on exertion, no chest pain, no hemoptysis. The FEV1 was 111%. The DLCO was 80% predicted on her PFTs. A 6-minute walk distance of 600 feet limited by hip pain and stiffness. The ECOG performance status for this patient is 1. Medical history, hypertension, hyperlipidemia, diabetes, and obesity. Again, she's a former smoker, 50-pack year history, quit 5 years prior with no drug or alcohol use, and no significant family history. Her PET scan showed a 3.9 centimeter lesion in the right upper lobe. And I'm going to go ahead and let Dr. Bala at least interpret what he is seeing here.
So on the CT images that are presumably may have been performed close to the PET CT in time, show this kind of clover leaf shaped nodule in the right upper lobe. And you'll notice on the image on the left, it has areas that are ground glass in that you can still see the vessels running through it. And there are areas more inferiorly on the second image that are more solid. And you can tell that because you can no longer see the vessels running through that.
Okay. And the PET?
And the PET CT is interesting because you can see that on the patient's left side of the lesion, there's a focus of increased uptake. And so on CT imaging, it can be really challenging to tell where on the adenocarcinoma spectrum you are when you're looking at a lesion, especially when it has ground glass elements. And the PET CT is helpful because the FDG uptake suggests that we're dealing with something that's more invasive now that we've got that focus of uptake. And so it would be in keeping with an adenocarcinoma instead of something a little bit lower on the spectrum, like a minimally invasive or adenocarcinoma in situ.
Okay, so the patient does have a bronchoscopy with biopsy. It is confirmed to be an adenocarcinoma, but the mediastinal lymph node interrogation and 4 and 7 lymph nodes are negative. So at least we have a mediastinal staging via EBUS. Sorry, R4 and 7. So the patient undergoes in July 2021 a minimally invasive right upper lobectomy. And I think we'll maybe pause there. And Dr. Puri, just back to you. How would you approach this patient in terms of the optimal surgery for this patient?
I think that I would go back a step to the preoperative workup. And this patient, I think, was appropriately worked up preoperatively for a tumor which is approximately 4 centimeters or so in size. And the patient has a performance status which is not 0 and has some degree of limitation of their physical activity, but the pulmonary function testing is appropriate. So in this patient, I would have had a detailed discussion about a minimally invasive resection. I don't have access to all the CT images, but one of the possibilities in someone with a somewhat smaller tumor in this particular location can be an apical segmentectomy to the right upper lobe of the lung, but something which is 4 centimeters in size, that would not be an ideal operation. If one had a 2 centimeter tumor in the apex of the lung and had a somewhat limited pulmonary reserve or limited functional status, then a segmentectomy with an adequate lymph node dissection would be a very viable option. But for a tumor which approaches 4 centimeters in size, it would be important to perform a lobar resection for adequate margins on that particular lesion. And I think that the preoperative workup for mediastinal staging and the physiologic assessment appears quite appropriate. As far as the operation is concerned, the standard of care in today's day and age for someone with presumed early stage lung carcinoma is to attempt to perform a minimally invasive lung resection. This is performed either thoracoscopically or using robotic approaches. In our own group, there are surgeons who do both. I personally generally perform robotic minimally invasive surgery, and a lobectomy with adequate lymph node dissection would be the appropriate operation for this patient, and it seems like that's what she had.
Dr. Puri, excellent overview. Can you give us some of the advantages of the robotic versus, other less science ways, I would say, more the advanced ways that you're looking at the robot and how you use that?
Right. I think that's a great question. There is not much science, but lots of opinion that can inform the answer to that question. So I'll actually take that one step upstream and compare minimally invasive approaches to thoracotomy. So till about, I would say, the mid-2000s, till 2006, 7, 8, the vast majority of lung resections in the country for early stage lung carcinoma were still being performed via an open or thoracotomy type incision. But in the last 12 years or so, 65, 70%, maybe even a little bit more of the early stage lung carcinomas are now resected in a minimally invasive fashion. It started with VATS, or video assisted thoracoscopic surgery, and VATS has over the years been shown to have advantages over thoracotomy in both prospective as well as numerous retrospective studies. These advantages are largely in the early postoperative period. So this is important for short-term outcomes, including perioperative complications. The faster they're able to come back to a baseline functional status, patient-reported outcomes, and performance status recovery, as well as, importantly, the ability to get adjuvant therapy in case one has upstaging. So there is, I think that of minimally invasive surgery is a major advantage, that when you compare the likelihood of receiving appropriate adjuvant therapy with someone who has surprise N1 or N2 disease or positive margins, it's 2:1. So you're twice as likely to be able to get appropriate recommended therapy if you've undergone a minimally invasive operation, because your performance status doesn't decline or recovers relatively quickly. And as far as comparing VATS to robotic surgery, the literature-based or evidence-based answer is that there likely is not that much difference between the two approaches in terms of early postoperative outcomes. However, we all follow what we are trained in, and as more surgeons have been trained in robotic surgery, it has seen a greater uptick in the general thoracic surgical sort of domain. But as of now, there is no clear-cut evidence showing that one is better than the other, VATS versus robotic surgery for lung resection.
Thank you for that overview. So this is the pathology from the final pathology for the case. This was an adenocarcinoma, 3.8 centimeter, negative margin, has spread through airspace, staph acinar predominant. We can talk about the relevance of that. And an R4 lymph node with microscopic tumor, but 15 other lymph nodes that are negative. So the final stage here, I believe, is a T2A N2, single station N2. Question is what is the best way to manage this patient who has a resected 3A tumor with an incidental N2? So Dr. Kamij, I'll turn to you first. What would you offer this patient? And I believe in their 60s, was able to complete the surgery. What's the optimal systemic treatment? And then would you do next generation sequencing on the tumor specimen?
Thank you, Dr. Levy. So this one is a little bit easier than the last case because they have nodal involvement. If that R4 is correct, then it's an N2 disease, so their chance of cure has dropped down quite a lot. So the case for adjuvant cisplatin-based 4 cycles chemotherapy goes up. One might think about cisplatin and pemetrexed as perhaps the best tolerated of the potential adjuvant options. One would like to confirm that the patient's renal function, that I believe they had some diabetes, that they don't have significant neuropathy or or neuropathy going on to assess that. I do think, given that, as we already discussed, there is a licensed adjuvant use of an EGFR inhibitor, I think the patient should have molecular testing. And then I would definitely have the discussion with Dr. Curran about the pros and cons of post-operative radiotherapy when there's a potential N2 nodal involvement.
Yeah, so this is a nice segue to my question to Dr. Curran. A lot of controversy here about the role of post-operative radiation for N2. Some of the new data, perhaps you can talk about your take on how you manage these patients with resected N2, and is there a role routinely for post-operative radiation therapy? And if so, how much, how long, how do you deliver it?
Sure. Yeah, great questions, Dr. Levy and Dr. Kamich. Thank you. So prior to the recent randomized data coming out of Europe, I would have clearly said on this case, I would not recommend post-operative radiation for a single microscopic N2 node in a well-resected patient who has 15 negative nodes. I don't think I supported that. I think if there's extranodal extension, multiple nodes, then that would be different. There is has been a recently completed randomized trial in Europe comparing patient post-operative radiation versus no post-operative radiation. And while we don't have the final result, there is no survival benefit. So for this particular patient, prior to that data or since data, I would not radiation. Adjuvant radiation, when it's given for positive nodal disease, typically is a 5 days a week, 1 day fraction of 3D conformal or IMRT type treatment targeting relevant target, 5 week, 5.5 week course.
And Dr. Kamich or Dr. Puri, back to you. Let's say this patient is given adjuvant systemic treatment, potentially radiation. It sounds like for single station N2 disease, Dr. Curran would not make that recommendation. What's the surveillance strategy here? How often do you scan these patients? I'll let Dr. Puri answer first. I think sometimes the surgeons, the medical oncologists have different strategies. Be curious to hear both of your perspectives on how frequently you scan patients and how often and for how long. Dr. Puri, I'll give you first crack.
Thank you, Dr. Levy. I think that's a fantastic question, which again has very little data to support what is currently recommended and done. Our strategy at our institution is to do, for completely resected patients, perform a 6-monthly scan for the first 2 years and an annual CAT scan subsequent to that. Our own institution has looked at a large data set derived from the National Cancer Database as part of a special studies section and compared what we thought were intensive or high density CT imaging strategies versus low density CT imaging strategies. And there really was no survival benefit in completely resected people. And our institution, we're also currently looking at another large VA data set. We're trying to either corroborate that particular finding from a national data set or refute it. So this is what we currently do. And again, the evidence is rather thin.
Yeah. Dr. Kamich, your thoughts, how the University of Colorado manages these patients?
I mean, I think Dr. Puri makes a great point. So when we sit on the national guidelines, in general, if I can sort of be a little flippant, the surgeons, of course, have all done an amazing job and feel that there's no need for surveillance. The medical oncologists live in fear of recurrent disease because that's what they spend their time dealing with and want to scan every week, which is why things like the NCCN guidelines say things like scanning can be anywhere between every 3 months to every 12 months to allow everyone to feel happy. I'm probably, the more intensive end. So we do every 3 months for 2 years, then every 6 months for 2 years. And then we go to annual, almost like CT screening. Again, what is the data to support this? Pretty slim. We do know that the risk of recurrence goes down fairly dramatically in the first 2 years. So more intensive during that period of time and becoming less intense later. I think everybody agrees on. Whether there are some nuances in there in terms of exactly other risk factors for recurrence, whether different molecular drivers make a difference, one has to wait and see. But it's, I think you do what your institution feels comfortable with, and you do need some kind of surveillance.
I would agree, Dr. Kamich. Just one other thought, any role or question, any role for longitudinal CEA levels to detect recurrence? You know, this is an older way of looking at things, at least in colorectal cancer, it's been looked at. And then ctDNA, which is, you know, a little bit probably more sensitive to recurrences and is emerging data. Do you see a use for any of these right now in your practice?
So one should ask the question as to what you're trying to do with surveillance. And it's interesting that Dr. Puri said in their analysis there was no difference in overall survival. And the question is that the appropriate endpoint? Equally, if you're looking for time to first detecting recurrence, if you don't act on that, is that the appropriate endpoint? I think what we're looking for is to see whether an early stage of recurrence could actually alter the management strategy. Could you have a second chance at curing with more aggressive local radiotherapy? And so the concept of an oligo-recurrent situation is actually what I think we're looking for in this scenario. To that end, yes, I actually do include serum tumor markers when I do those CT scans, and I use them only for this reason. If I get the CT scans and they say there's no evidence of recurrence, but for example, a tumor marker is going up, I don't act on that other than to say, I think the CT scan is missing something, and I will then do a PET scan. And certainly in my experience, I have found lymph node recurrence or bone mets, which have previously not been detectable, and I do tend to find them at an earlier stage of recurrence. I don't think there's any role for ctDNA at present because I don't think it's sensitive enough to pick up these very small deposits.
Okay. So in summary, and we're going to move on, it sounds like for this case, certainly a recommendation for adjuvant cisplatin-based chemotherapy, potentially 4 cycles of cisplatin pemetrexed, checking the renal function, given that this patient was diabetic, and that was a good pickup, Dr. Kamich. And then given that this is single station N2 and in light of the new European data, no formal recommendation for radiation consolidatively, unless maybe it was multi-station N2, then a consideration, but it sounds like for this, no formal recommendation for radiation. And then for surveillance, looking at CT scans, depending on the University of Washington, St. Louis, or University of Colorado, every 3 to 6 months for the first 2 years, and then maybe annually after that, or maybe 6 months for 2 to 4 years and annually after that. So sounds like there's no hard and fast rule on that, but certainly surveillance needs to be instituted at some level, perhaps more frequent at the early part post-operatively, and then spacing it out a little bit after a certain time frame, whether that be 2 or 3 years, and then on to a total of 5 years.